So I now call upon Dr. Parth Verma to tell us about the dose-escalated adaptive radiotherapy for bladder cancer.
Morning, everybody. So we've already heard about what we can do or what we should do when we get to take the bladder out for muscle-invasive bladder cancer. I'm Dr. Parth Verma, and now we'll be talking about what we can do should we choose to let the bladder stay inside and yet treat the bladder cancer. Just a small bit of background for my colleagues who are not frequently treating bladder cancer with radiotherapy. As we know, it's a mobile organ. It doesn't stay the same throughout the course of treatment. And a traditional RT would involve us giving radiotherapy to big areas around the bladder, leading to lots of unnecessary toxicities, which makes the case for adaptive radiotherapy, where it allows for better tissue visualization. We can choose from a battery of various plants which suit the position of the bladder for that particular day, which we call plan or anatomy of the day. And there is also the potential for us to increase the dose safely. Talking about the RADAR trial, it was an international multi-center, multi-arm, two-stage, phase 2, parallel cohort randomized control trial. They randomized 345 patients with unifocal, non-metastatic, node-negative bladder cancer. They were randomized with a 1:1:2 ratio into three different cohorts. Standard whole bladder radiotherapy, which was the control group. Mind you, this did not have an adaptive component to it. There were two adaptive arms, that with the standard dose and that with a dose-escalated regimen. They involved the uninvolved bladder getting 52 or 46 gray, with the tumor getting something up to 64 or 55 in the standard dose, or 70 in 60 in the dose-escalated arms. And a daily CBCT was done before every fraction was delivered. 1 out of 3 predefined plans, small, medium, or large, were verified according to the position of the bladder, and the treatment was delivered. Standard concomitant radiosensitization therapy was used, and the regular follow-up we can see here. Now, there were 2 stages to the trial. Stage 1 was feasibility assessment, and stage 2 was about the toxicity. For stage 1, they were looking at the patients, the proportion of the patients who received dose-escalated radiotherapy, who met the predefined organs at risk constraints for the medium plan of the 3. For those that did not meet the pre-specified constraints, a decision was taken as to whether DART can be delivered safely, or should the patient be brought over to the SART arm. And for the toxicity evaluation, they were looking at late radiation-induced CTCA grade 3 or above toxicities in 6 to 18 months, and they wanted for this to be less than 20%. An evaluable patient was one who had at least 1 fraction of radiation therapy and at least 1 toxicity assessment within the 6 to 18 month period. And these were the secondary endpoints. We'll get to those. Now, it's a busy slide. I just want to point out that the patient characteristics between both the groups were well balanced, and the consort diagrams, although quite busy, we'll get to the results. So, results of stage 1, feasibility assessment. They saw that of the 20 fraction DART group, 86% participants were able to meet the constraints. For the 32 fraction arm, around 90% of the participants were able to meet the constraints. Talking about the adaptive plan usage, of the 6,222 fractions delivered, 37% used the small plan, 21% used the large plan, and here comes the kicker. 70% patients used all 3 plans at least once throughout the course of their treatment, and less than 2% used the same plan throughout. Coming to the toxicity evaluation, long story short, the primary endpoint was met. There were less than 20% grade 3 or above radiation-related toxicities. For the 20 fraction arm, whatever toxicities we get, they were quite comparable, and there were none in the 32 fraction arm. Coming to overall any late toxicity, in the 20 fraction arm, it was around 9%, and the 32 fraction arm as low as 5%. It is worth noting that even the upper border of the 90% confidence index did not breach the 20% that was mandated. Now, 2-year cumulative incidence of RTOG grade 3 toxicity, as we can see, it's lower than the historical data that we have for bladder cancer, BC 2001 trial, which was 13%. Here we had 2.4 and 1%. Even the patient-related outcomes seemed to be complying. Now, the disease outcomes. Mind you, the trial was not powered for this, and there were no statistical significant differences that were noted. Coming to another very important point, salvage cystectomies. While most of the salvage cystectomies were for disease recurrence, the overall salvage cystectomy rates remained quite low, less than 4%, and there were no cystectomies due to any adverse events. That also compares favorably to the BC 2001 trial. Nodal recurrence, mind you, these patients did not receive nodal RT. The nodal recurrences still were low at 7% overall. So the key takeaways from here, they were able to successfully escalate the dose with low toxicities, lower than what we have seen with other trials in the past. It emphasizes that adaptive radiotherapy is here to stay. And additionally, they also saw a trend towards improved locoregional control, although it was not statistically significant. The overall survival was similar to the cystectomy series, and salvage cystectomy rates were low. In terms of limitations, of course, it's a phase 2 design, not powered to compare the efficacy. The overall toxicity was low here. While this favors well for the patients, it makes comparisons a little difficult. And the PRO assessments were compromised by a change in one of the instruments. The clinical implications here are escalation of radiotherapy is safe and feasible. Adaptive radiotherapy can be delivered across centers if you have the proper training and the quality assurances. And the adaptive nature, the multiple plans, it's here to stay. How about things closer to home? I'm happy to present the work of one of my colleagues. Dr. Anudhara Radhakrishnan presented this at ESTRO last year. We reported the early clinical experience with a shorter radiotherapy schedule, that is hypofractionated RT, in muscle-invasive bladder cancer, and we compared the toxicity and early efficacy outcomes. Now, this was a retrospective analysis. We took non-metastatic bladder cancer, muscle-invasive bladder cancer patients who were treated with curative radiotherapy. These were the two cohorts we have. From 2009 to 2020, those with a conventionally fractionated 60 to 64 gray with the pelvic nodal treatment. 2021 onwards, based on the IPD meta-analysis, shifted to 55 gray and 20 fractions with a 44 and 20 to the pelvic lymph nodes. All of these were treated with adaptive plan of the day IMRT with daily image guidance. Chemotherapy as per institution protocol was allowed, and that's the follow-up that we followed. Toxicity assessment and efficacy outcomes that we looked are presented over here. Now, I would just like to point out there are very comparable groups, except the sample size, obviously. But bulk of our patients received bladder and pelvic node radiotherapy. Now, coming to the results, overall completion of chemoradiotherapy was north of 90% for all the groups. Low overall GI and GU toxicities were seen, both acute and late, and these were similar across the conventional and the hypofractionated groups. There was slightly higher grade 2 late GI toxicities in the hypo group. It is approaching significance, probably something with a longer follow-up. We might have a little bit more data to talk about over there. Outcomes, although these are early outcomes, we don't have any significant differences to point out. The median follow-up is 32 months. It's 21 in the hypofractionated group. That's worth noting. And coming to the limitations. Now, this is a retrospective analysis. We have a single institution experience that we're reporting over here. And the median follow-up for the hypofractionated group is comparatively shorter. So the late toxicity and efficacy data is still maturing. But the key takeaways that I would like to talk about, we have a real-world experience that hypofractionated radiotherapy has similar acute and at least the early late toxicities compared to the conventionally fractionated ones. And these toxicities are despite concurrent gemcitabine and pelvic radiotherapy being delivered. Something worth looking into. Thank you.